with our first session, which will be my presentation on hypertension and diabetes. I hope you can all see my screen. I would like today to, with regard to hypertension and diabetes, address some of the important clinical points that maybe we, on many occasions, do not do or engage in. So you all know very well that hypertension and diabetes are like twins. They both very frequently come together, one lead to the other, and the presence of both is a major health risk. In type 1 diabetes, hypertension and diabetes is a major risk for kidney problems as well as for retinal problems. In type 2 diabetes, obviously the main concern is the added cardiometabolic risk impact with all the cardiovascular problems on the vascular system in general, cardiac, cerebral and peripheral arterial, as well as the kidney as well. What I would like to address in my presentation is simple points regarding to the targets. Achieving any target in life is make everyone very happy. As an Egyptian and as a Liverpool fan, I was greatly happy to see Salah lifting the Champions League Cup exactly 12 months ago. But in hypertension, we have systolic targets and diastolic targets. In general, the target for systolic is below 140. We can aim for lower to below 130 in certain circumstances, such as those with target organ damage, as long as the patient can tolerate this without adding extra burden. For diastolic, the target is below 90. Of course, in certain circumstances, such as high-risk cardiovascular for both, we would like to aim for a diastolic below 80. So below 130 over 80 is for the high-risk patient, but the general patient, we say below 140 over 90. That is according to the ADA recommendation. This is the British and Irish Hypertension Society algorithm. And I'm not going to discuss at all which drug we start, which combination. We have, maybe this is the scope of another presentation. What I would like in my brief presentation to focus on is something that many of us do not address, which is the lifestyle changes and the importance of education and home blood pressure monitoring for people with hypertension in general, specifically for hypertension and diabetes. This is one of the standard points, and it tends to be ignored, and we tend to add more and more therapy, ignoring this crucial factor. This is word for word from the guidelines. Offer lifestyle advice and continue to offer it periodically. So you just don't mention it once and then you forget it. Every time you see your patient with a blood pressure above the target, you need to reinforce the lifestyle measures. And the other important point, we ask our patients with diabetes to check the blood glucose at home. It is well worth to ask the hypertension person to check their home blood pressure and to provide them with the right training and the right advice regarding how to use it and how to maximize the benefit of lifestyle as well as the therapy thereon. Here is the European Society of Hypertension and the European Society for Cardiology guidelines on methods to improve adherence to treatment. We know many patients take their tablets for a short course and then they stop. Many get bored with a chronic condition such as hypertension and diabetes. Many are not certain what is the benefit and why should I take the tablets. So part of the recommendations of the European Society for Hypertension and Cardiology guidelines is the group session, the self-monitoring of the blood pressure, and the self-management with simple patient-guided system. And this is the main point which I want to focus on today. We have taken part when I was working in UK before I leave into this important randomized control trial. The photo in the screen, you see it, is for Professor Ingrid Mulhauser from Germany. I got to meet her in a meeting in Egypt. She's one of the most eminent people in Germany for patient education in general, and they were applying a hypertension program, but they never did it in a randomized control trial. I'm delighted that this study has the collaboration of two of the faculty of diabetes and endocrinology from Alexandria University, Kamel Hamida and Ahmed Swidan, as well as my colleagues from UK. In this randomized control trial, we included 132 participants who were randomized into either an intervention group or a control group. The details of the plan was for the structured education with home blood pressure monitoring. The participants were invited to attend once weekly for 90-minute session over 4 consecutive weeks. Okay, the session was done in groups. Each group would include 6 participants. As I mentioned, the education program was originally done in Düsseldorf in Germany, and we've modified it to be convenient for the people in UK. And the education was provided by the nurse, a dietitian, as well as the doctor, the specialist, who was able to adjust the therapy for the patients as well. It was very simple. It was for making the person with diabetes, we call it the SHED study, which was structured hypertension education in diabetes. And we wanted the person with hypertension to understand that, number one, what is hypertension, and that it is his own problem, not my problem as a healthcare professional, because sometimes this is not really clear in the patient's mind. We wanted to explain to them what raises the blood pressure of an individual in everyday life, such as, for example, stress, such as, for example, lifting heavy objects, and so on. And what's the difference between systolic and diastolic blood pressure? When patients, you say to them the top figure and the lower figure, they don't understand many of this. We wanted to explain to them what are the common causes of hypertension, and also what are the less common causes for hypertension, which include the endocrine problems, the vascular problems for the renal arteries, and kidney problems in general. To make it clear to them, we were explaining to them in this session the impact of hypertension on the various parts of the body, the potentials for a stroke, for heart attacks and heart failure, the potential for kidney failure, as well as the potentials for circulatory problems. And when it came to I'm just obviously flying on some of the main messages. And when it came to the home blood pressure monitoring, of course, we had one blood pressure monitor, and they were advised on how to check at home the blood pressure, how it is done properly, and so that they can get the blood pressure done with good accuracy. Key points was in the management of hypertension, for example, related to salt intake and salt restrictions, and explaining to them what is the recommended daily salt. And we wanted to reduce from an average in UK of 10 grams per day to 5 grams per day for those with hypertension. And what would be the effect on this on the blood pressure, which is reported in studies to lower the blood pressure of systolic, 5 systolic and 2 diastolic. Also, the effect of weight reduction, the effects, of course, in UK, as alcohol intake is high by many groups, the impact of alcohol intake, and very importantly, the effect of physical activity on blood pressure management. Now, many patients, when they read the label and they read the word sodium, they cannot relate the word sodium to salt. So we're trying to explain to them when it is recommended to read the labels and to check for the sodium content or the salt content of how can they make that correlation, and to make to them clear that for every 0.01 of sodium, the salt equivalent of it is to multiply it by 2.5. So a person who is buying a packet of whatever, let's say crisps, and it's written on it the 0.1 salt or sodium, when they multiply by 2.5, it becomes a quarter of a gram of salt that they can understand of what we add every day. Now, of course, in our Egyptian and Middle Eastern lifestyle, there is so many hidden salts. We love eating olives, we love eating cheese, we love مخلل, pickles, we love nuts, and most lib and Sudani and many of this. We love our sardines and our fasikh and our ringa and many other, all the canned food. Of course, this contains a lot of salt, let alone the added salt that we add. I am guilty of this for many years until I started to stop, and I used to add salt even without tasting the food, until it became clear to me that I need to change this habit so that I can reduce my salt content. Now, we prescribe many medication to our patients, and they need to understand and expect, what does this drug do? And what this group of drugs do to my body? What is the important effects they do? And equally, what is the expected side effects of a drug, so that they can anticipate it and tolerate it if it happens, and report it to us if it's excessive, so that we can relook and readjust on the dose. We explain to them the principles of the balance of good health, the BOGH, and how we split the plate with the amount of fruits and vegetables. And alhamdulillah, we are in Egypt with plenty of fruits and vegetables, and they are not excessive in price in comparison with the cheese, the meat, and the other products. So understanding the distribution of how much of each component is really quite important. Now, the big question that every one of you would say, did this work? Did education and knowledge, as well as home blood pressure monitoring, manage to help in a randomized controlled trial? Now, I want you to bear with me for the next slide, because it's a busy slide. So I want you to take it, and here the color code. Blue is the intensive arm, and green is the routine arm. And here, visit 0 is when we started, visit 1 is 12 weeks, visit 2 is 24 weeks. Now, I want you to see the change in systolic blood pressure in the group that had the education. The blood pressure dropped by -18. In the group that had the routine service, it dropped by 15. When you look into the diastolic blood pressure in the intensive education arm, education helped the blood pressure to drop by 7 millimeters for diastolic, while in routine service, this was only 3. These changes from one step to the other, from visit 1 to visit 2 to visit 3, in each arm was significant. So what you do as a clinician and intensifying the therapy helps, but also education helps. When you look into the achieving targets, I would urge the colleagues to mute their microphone, please. If any of the colleagues have their microphone on, please mute it until we open for presentations or for chat. So let me complete. So when you look here into blue is the education group. After 12 weeks, here is 55% achieved the target blood pressure versus roughly about 22%. In visit 2, after 24 weeks, 6 months on, even more in the education group versus the control, the routine service group. But more importantly, how was that achieved? In the education group, we only increased medication by a mean of 0.2 tablets, while in the control, the routine group, the medication increased by 0.62, and this was statistically highly significant. So not only we had lower blood pressure and higher proportion of people achieving the target, but this was also done with less medication. So it's not just about adding more and more tablet, it's making patients aware of what we're doing. Another important part, when we compared the blood pressure readings of the patient at home with the blood pressure in the office, they were matching for systolic and diastolic. So the accuracy of home blood pressure monitoring is now pretty good, and it's something we can rely on. As I mentioned, in the Middle East, in Egypt, and in many Middle Eastern countries, we are among the highest globally for consumption of salt. The salt intake for many of us is really quite high. What is recommended is 5 grams per day as per the WHO and per many of the other societies. This is a paper published in Circulation just 1 year ago. This paper focused on how can we save roughly about 94 million lives globally by simple 3 interventions. 1, to increase the accessibility of blood pressure treatment to 70%. 2nd is to reduce the sodium intake by 30%. And 3rd is to eliminate the intake of artificial trans fatty acids, the SAMNA, as you can see. And they considered that the impact of sodium reduction would be equivalent of hypertension. And they wanted to see the impact of these 3 interventions on the lives of people globally. And here is the very interesting data. This is for men and this is for women. If you apply that process, the 3 interventions, you would save over 40 million lives of women and over 50 million lives of men. But more interestingly, when you look into the impact of salt, it is more than the impact of increasing hypertension treatment. If you were to look into combining both, you would save 35 million lives of women and 45 million lives of men. And that is really quite important. So it's really important that we remember, this is my last slide, is the conclusion. The conclusion, I take it again from the American Heart Association. Before you think of just increasing the medication, think of adherence of your patient and think of tools to improve the adherence, the education, the salt reduction, the blood pressure monitoring. So what we really need is education, 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 which includes home blood pressure monitoring. I hope my presentation was clear. I will now stop sharing